All right, chapter 26, abdominal emergencies. So in this chapter, we're going to go through abdominal physiology and anatomy, as well as, pain and discomfort, different conditions that you can have, and how to assess those conditions. So the abdomen contains many organs from a bunch of different body systems, which can make figuring out what's wrong very difficult because there's a lot going on in the abdomen. The other thing that can challenge us a bit is that the nervous pathways throughout the abdomen connecting different organs to different areas within your body can cause a lot of referred pain. So these patients that we're having that are complaining of abdominal pain can be really difficult to track down exactly which organ is causing the issues. The plus side of all of that is that it doesn't necessarily matter if we have a specific diagnosis between one organ and the next organ. Most of the treatments across the abdominal problems, as far as EMS is concerned, are very, very similar. Okay, so that's kind of the silver lining to all the difficulty surrounding abdominal related problems. So the abdomen is the region between the diaphragm and the pelvis, contains a whole bunch of organs from digestive, reproductive, endocrine, and regulatory systems. Between the different organs, or all of the different organs that we're dealing with, there are two different types. We've got solid organs and we've got hollow organs. So the solid organs would be the spleen, the liver, the pancreas, kidneys. Those are the solid organs. Hollow organs would be stomach, gallbladder, intestines, the actual bladder, right? So there's those two differences. Now, why do those differences matter? Well, one, just in functionality, it makes a difference. But also when we're looking at trauma situations, how we expect these organs to react, a lot of the times is based on whether or not it's a solid or a hollow organ. So, for instance, a splenic laceration, if you were to get a laceration to your spleen, the spleen is going to hemorrhage. It's very vascular. It's a solid, dense organ. So when you get a laceration, it's going to hemorrhage, causing internal bleeding. Big problem, right? Hollow organs, say if you rupture your bladder, you've got a bladder that then pops. Now you're going to not really be leaking blood into your pelvic region or lower abdomen, but you're going to be leaking the contents of the bladder into that region. And now you're going to get very diffuse pain because pretty much anything that all of these organs carry, whether it's bladder or bowel contents or stomach contents, none of it feels good when it's just released into your abdominal cavity. All of these organs are fairly sensitive, and they're going to start not feeling good. You might start to get some inflammation that's happening as well as some pain. So how our body reacts is going to be a little bit different in each of these situations. The abdomen is divided into 4 quadrants when we're assessing it. We've got our right upper, right lower, and left lower quadrants. And how we describe to other providers where the pain is at is based on those 4 quadrants. So the quadrants are divided at the umbilicus. So if you were to draw a line straight up and down from the abdomen through the umbilical cord or belly button, and then crossways through the belly button, it kind of makes a big cross. That is where our quadrants are going to be. So if we kind of overlay this picture on top of the pictures that we saw a minute ago, so kind of imagine those pictures there, you can see exactly where these organs are going to be divided up. Okay, so you can see the lower quadrants are mostly going to consist of intestines, and there's a funky little organ over here that's not pictured, the appendix, that's in that quadrant. But for the most part, lower quadrants are going to be either reproductive or intestinal issues. Upper quadrants is where it starts to get a little bit more tricky with all these solid organs kind of put in there too. Okay? So the peritoneum is a thin membrane lining the abdominal cavity and covering each organ. Parietal peritoneum attaches to the abdominal wall, and the visceral peritoneum covers each organ. So all 3 of our cavities within our body have some sort of lining. Depending on where it's at, we use different descriptors. So peritoneum would be in reference to your abdominal cavity. If I were to say pleura, that's essentially the same thing. It's this thin membrane lining, but the pleura is around the chest cavity, so kind of around our lungs. If I were to say dura, D-U-R-A, the dura is around the skull cavity, kind of in that area, all right? Parietal versus visceral are just other descriptor words as well. So parietal always covers the cavity. So in this case, the abdominal cavity. Visceral always covers the organs. In this case, the abdominal organs. So if I were to say parietal pleura, pleura referring to the chest cavity, parietal referring to the cavity itself, that would be essentially the same thing, this thin membrane covering the chest cavity, as opposed to a parietal peritoneum, which is going to be that thin membrane covering the abdominal cavity. Okay, so these are just descriptor words for this thin membrane that's in these areas. Okay. Most of the organs in our abdomen are going to be enclosed within this peritoneum. A few lie in the extraperitoneal space, so just on the outside. Kidneys, pancreas, and part of the aorta all lie behind that space, called the retroperitoneal space, and it's all just behind it. The bladder and part of the rectum lie below the peritoneal cavity. Okay. Female reproductive organs and structures lie within the abdomen and the pelvis, so ovaries, fallopian tubes, uterus. We've also got a lot of very large blood vessels, so the aorta, vena cava, hepatic arteries, splenic arteries, iliac arteries are all kind of in that area as well. So lots going on in our abdominal cavity. So this image is a cross section, so if we were to stand kind of sideways, cut the body in half, this is what you'd see in the abdomen. So you can see this is a female patient. We've got a uterus right here that's kind of outside the space. So you can see this thin blue lining. Hopefully you can see it on your screens here. If not, this picture is in your textbook as well. But this thin blue lining goes all around these organs. Underneath it, that's where we've got our female reproductive organs, as well as bladder, part of the rectum, etc. Okay. Behind it, that retroperitoneal space, is where we've got our aorta that kind of sits, as well as pancreas and so on. It's kind of behind it. Okay. So now we've got an issue. We've got pain. We've got some sort of discomfort. Well, visceral pain. This is pain that's originating from the organs within the abdomen. Again, visceral referring to the organs. There are fewer nerve endings within our organs or within that visceral covering. So when we feel pain, it's very diffuse. It's a dull or an achy, sometimes classified as intermittent or colicky type pain that's happening from these organs. Okay. Intermittent, crampy, colicky, all hollow organ features. Okay, so that makes a difference as well, as whether or not the organ is hollow or solid. But again, all kind of diffuse. Persistent or consistent pain often originates from solid organs. So the type of pain that the patient is experiencing and how they describe that pain, dull, achy, crampy, all kind of refers to organ versus the space. Parietal pain. So this is, again, referring to the space itself, that lining that covers the space. There's a lot of nerve endings in this particular type of lining. And that being said, when we have pain, we can usually describe it as sharp. We know exactly where that pain's at. It is right here that hurts, as opposed to, oh, it's just, the whole lower abdomen hurts. Okay, right here hurts. Oftentimes that's going to be the parietal peritoneum. Tearing pain. Oh, that's a bad day. We don't like to hear that one. So tearing pain is fairly specific to the aorta or the stomach? Usually the aorta, but it can be either one. Typically, this type of pain is felt when there's some sort of separation that's happening within the layers of the aorta caused by aneurysms, usually by dissecting, like actively dissecting aneurysms. Depending on where the aortic aneurysm is at and where it's dissecting determines where the pain is going to be located with the patient. For instance, your aorta goes from your heart all the way down the center of your body, or just about the center of your body, all the way down to where it splits into like your iliac arteries, which is going to be in your pelvis, okay? And it splits into left and right to go down your legs, eventually going into the femoral arteries and so on and so forth, okay? That part's not nearly as important, but the aorta is huge, right? It's one of the largest vessels within your body, length as well as diameter. So depending on where the dissection is happening is where you can kind of feel the pain. So sometimes it'll be in the chest, and we'll have patients tell us that they're having chest pain, but it's actually an aortic aneurysm. If it's lower down, say an abdominal aortic aneurysm, oftentimes they'll have back pain. Remember all the way back to that picture a second ago? This one. The aorta is closer to the spine when it comes through our abdominal cavity than it is to the middle or the front, right? It's towards the back, well protected by that spine, right? So because it's towards the back, oftentimes that pain is going to be felt as back pain, not as stomach pain. Classically, anyways. Okay. Referred pain. So referred pain is the perception of pain in skin or muscles at distant locations. So we've got neural pathways throughout our body, right? Organs connecting to different muscles and so on and so forth, right? Throughout our body. So certain instances, someone will have pain, usually organ pain, that is actually sending signals of discomfort to different areas, usually unconnected areas of the body. There's one that we're very familiar with. Somebody's having a heart attack, but they also have left arm pain and jaw pain. Why? How is the jaw related to the heart? Well, it's the nervous pathways, right? Your abdominal organs are no different. They also have nervous pathways that go all over the place, right? So getting into abdominal conditions specifically. So appendicitis. So this is an infection. Anything itis or itis at the end is going to be an infection. This is an infection of the appendix. Signs and symptoms: nausea, vomiting. The very classic one is pain in the right lower quadrant. Remember back to our quadrant markers, there's not really much in the lower quadrants other than intestines and that pesky little appendix. So right lower quadrant pain oftentimes is going to be appendicitis. Classically, that pain starts in the umbilicus, so right around the belly button, and then it kind of, as it progresses, it shifts into that right lower quadrant where it settles and has a lot of pain. Fun fact, if you have somebody that does have appendicitis and you tap the bottom of their feet, and it has to be a fairly sturdy tap, I mean, we're not punching them, but a fairly sturdy tap on the bottom of their feet, that will send vibrations up to the appendix, and it will cause an increase of pain. That's not something we do classically civilian side, but Army medic side, where we have limited resources, oftentimes we'll have our patients that we think might have appendicitis, we'll have them jump up and come back down on 2 feet, and that will increase the pain in their abdomen. Anyways, fun fact. Yeah, not a whole lot we do for appendicitis. Comfort measures, oxygen, take them to the hospital. Peritonitis. So this is irritation and inflammation of the peritoneum caused by foreign material in that peritoneal space, that abdominal cavity, right? Parietal peritoneum is sensitive, especially to acidic substances. Irritation causes voluntary contraction of the abdominal muscles, and signs and symptoms, you're going to have abdominal pain and rigidity, just kind of generic, my stomach doesn't feel good, right? and not in a vomiting type of way, but in a cramping type of way. Again, not a whole lot we do. Supplement with oxygen if they need it and keep them comfortable. Cholecystitis. So this is inflammation of the gallbladder. This is also associated with gallstones as well. Often caused by a blockage of bile flow by the gallstones. Signs and symptoms often get worse with the ingestion of fatty foods. Signs and symptoms: severe right upper quadrant pain or epigastric pain. Epigastric kind of being the lower portion of the chest cavity, upper portion of the abdominal cavity. And pain is often referred to the shoulder. So 2 things here that you will probably get asked questions on. Pain referred to the shoulder, cholecystitis, pain to the shoulder, and then worsened with ingestion of fatty foods. Those both are kind of hallmarks of cholecystitis. Okay. Pancreatitis. So this is inflammation and swelling of the pancreas, common in patients with chronic alcohol abuse, although not limited to patients with alcohol abuse. Anybody can get this. Signs and symptoms: epigastric pain, often referred to back or shoulder. So again, back or shoulder is the referred pain for pancreatitis. That is a wonderful question that they love to ask on the National Registry. So make sure you're studying those. Gastrointestinal bleeding or GI bleeds. This is bleeding anywhere within the GI tract. Where is our GI tract? Well, it is from the esophagus all the way down to our natural exit point. It can be anywhere from minor to severe, causing little issues to major issues. Blood eventually will leave the body if it's in the GI tract. Now, if it is above the stomach, or stomach and above, I should say, it will come up with vomit. Your stomach does not like blood at all. It irritates it quite a lot, actually, so it usually will come up very quickly with vomit. If it is lower than the stomach, usually it will be forced out through the rectum. Okay, with the bowel movements. Oftentimes this is painless. It depends on where it's at and what it's doing. Say if it's in the form of like an ulcer in the stomach, that usually does come with some pain. But if it's just like slight tearing or bleeding within the linings of the intestines, usually there's not a whole lot of pain. Maybe a bit of an upset stomach or just kind of a crampy, like diarrhea type feeling, but not a lot of pain. Signs and symptoms: vomiting blood. Absolutely. Any sort of blood-like substance in the stools or in the vomit. As blood goes through the digestive system and it gets digested, it turns from red blood as we know it into kind of a dark, sludgy, coffee ground-like material. So it's not always easily recognizable for somebody that doesn't know what they're looking for, because it doesn't always look like blood if it's been digested. So they've got a bleed right below their stomach. That blood has to go through the entire pathway of the intestines, getting digested the entire time, and it's going to turn into that coffee ground-like material. Okay. Frank blood is like a bright red blood. So if you have somebody that's got frank blood or bright red blood coming out of their rectum, usually it's associated with things like hemorrhoids, although not always, but that's usually the first thing we think of. And again, pain can be anywhere from absent to severe depending on what's causing the bleeding. Okay. Again, not a whole lot we do for these patients. Be aware that they are losing blood. It is a form of internal bleeding. They do need to have fluids given, whether it's fluids in the form of normal saline or electrolytes or blood replacement. They do need to go to the hospital. And if they've got a lot of pain, we certainly can call ALS as well. But as far as basics, you're not really going to do a whole lot. Comfort measures, essentially. Abdominal aortic aneurysm. So this is a ballooning or a weakening of the inner walls of the aorta. Your aorta is made up of several different layers. We've got inner layers and outer layers. When there's micro tears on the inside, whether it's caused by trauma, high blood pressure, clots, whatever it is, plaque buildup, the blood that's traveling past can kind of get up in between the layers and start to separate or dissect the aorta. The aneurysm itself just refers to kind of the ballooning or weakening of those walls. Eventually, it does have the likelihood of rupturing. So lots of people have aneurysms. They sit dormant. The patient oftentimes doesn't know that they have one. Sometimes it's kind of stumbled upon through just normal scans that, oh, hey, by the way, you've got this aneurysm. But the aneurysm itself is not usually painful. It's when it dissects or ruptures that the patient starts to have pain. Unfortunately, if we're at the point of it rupturing, there's not really a whole lot you can do, or anyone can really do. If it's the point at dissecting, there are some things that they can do to try and either stop or repair those layers. But yeah, rupturing. And the reason, there are things that they can do, but because it's such a large vessel, if it's actively bleeding, oftentimes the patients will bleed out before they're able to make it to the hospital. Hernias. So this is a hole in the muscle layer of the abdominal wall, allowing tissues or parts of organs, usually intestines, to protrude up and against the skin. So this may be precipitated by like heavy lifting, if there's any sort of like aggressive lifting that's going on where they're tearing or ripping abdominal layers. This can happen. It can cause strangulation of the tissue or bowel obstructions as well, depending on how bad or where the hernia is at. It certainly requires transport to the hospital for evaluation. Now, lots of people out there have hernias and they live with them very happily. There's lots of different reasons for that. Sometimes they're not surgical candidates for this reason or that reason. Again, that's above our pay grade as EMS. That's more of a surgical question. Other times they're not candidates for surgery for different health reasons that are going on as well. So if we come across a patient that has a hernia, it's a good idea to ask them if that's new or if that's been there for a little bit. You'd be surprised how many people just have hernias that they live with on a daily basis. Okay, so always make sure that you're asking if it's new or not. Signs and symptoms: sudden onset of pain if it's an acute problem, palpable mass or a lump in that abdominal wall. Renal colic. So this is severe words are hard. Severe flank pain caused by kidney stones traveling down the ureters. So signs and symptoms of this would be severe back pain, or pain in the groin, nausea, vomiting. History of kidney stones would be another one. Yeah. Again, not a whole lot we do for these patients. Comfort measures. Any sort of cardiac involvement. So heart attacks are funky. We just learned about referred pain, right? There's those pesky nervous pathways that go throughout our entire body. Depending on where the issue is at in the heart, it certainly can cause problems with indigestion, digestive problems, epigastric pain, or that abdominal pain that's going on. So even if we've got a patient with abdominal pain, but they've got a significant cardiac history, or we just have that funny feeling in the back of our head that, hey, maybe this is cardiac, it certainly makes sense to do a 12 lead with those patients just to be on the safe side. Okay. Abdominal pain associated with female reproductive system. So the most serious one could be the ectopic pregnancy. This occurs when the fertilized embryo implants outside of the uterus. This is anywhere outside the uterus, commonly fallopian tubes, but it doesn't have to be. It could be just anywhere in the abdomen, actually. Rupture of those ectopic pregnancies can cause life-threatening internal bleeding, certainly a lot of problems. Really good question to ask your patients is, are they pregnant or could they be pregnant? Ectopic pregnancies, when you take just a standard pregnancy test, will show up as positive, usually anyways, so to my knowledge. So certainly ask those questions. Also, if they say, oh yeah, I'm pregnant, well, how far along are you? Oh, I'm 20 weeks pregnant. Okay, now we start getting into like the OB care, and is this, early labor, or is this a miscarriage, or so on or so forth, right? So we kind of go down that pathway of questioning. So assessing these patients. Our role is not to diagnose. Again, our treatments for pretty much all of these that we talked about is going to be treatment measures. Oxygenation if necessary, keep them comfort, so on, right? Call ALS if needed. So our need to know if this is cholecystitis versus appendicitis or pancreatitis is not that important. But we still need to do a thorough assessment. If we can figure out what it is, that's wonderful. Or even if we can get enough information to know what it's not, that's good too. So we'll go through and do a good line of questioning, get hands-on with our patients, do an actual assessment of the abdomen, all of that. That's all I pretty much talked about. Female patients, again, asking about pregnancies, menstrual cycles, could they be pregnant, etc. All really good. Are they using birth control? Sample history, perfect. Inspection. So we're looking, when we inspect the abdomen, we're looking at distension, discoloration, and any protrusions that we see. Protrusions being like hernias. We're going to palpate. This says use your fingertips, but I want to make sure we're clear. You're using the pads of your fingers, not the tips of your fingers. Okay? Tips being like straight down, pads being kind of at an angle. The reason being is if we're going straight down, you can certainly cause some more discomfort. Pads are going to tell you a little bit more, and you can push a little bit harder without it being a jabbing sensation. We're looking for painful areas, any rigidity that's happening, any guarding. So if the patient like is kind of bent over or kind of guarding their abdomen, that would be a sign. And then if we already know, hey, they told us that their right lower quadrant hurts, we're going to assess that last. Certainly get some vital signs. A lot of the patients that we see, they might just have general abdominal distress, like they ate some bad seafood, or, you know, that's a big one. Maybe they've got some like irritable bowel syndrome or something going on. Maybe more chronic issues like Crohn's disease. All of those things we do get called for. It could be something as simple as the flu as well, right? So we'll just go through our questioning and trying to figure out what's going on. Maintain that airway, keep them as comfortable as possible. If we're laying people on their sides, we try to lay them on their left side. Left side because that takes all of the pressure of the abdomen off of the inferior vena cava. Pressure from your abdomen, if you have a larger abdomen, whether it's fat or pregnancy or whatnot, all of the pressure on your abdomen kind of sinks down up against your inferior vena cava, which cuts off blood supply back to your heart, that return blood supply, and it can cause supine hypotensive syndrome. So we always, if we're laying patients on their sides, we always want to lay them on their left side. All right, that was the end of this chapter. It was a pretty quick one. Let me go ahead and stop recording here.